Thank you so much for joining us. We're at our 7th Wild event, and welcome to you if you're here for the first time. Welcome to you if you've come a bunch of times, especially welcome if you've come all 5, 6, or 7 times. We're just, really in awe of our community here, whether you're an emerging leader, whether you're a senior leader, all of the researchers and clinicians. There's even a policymaker or two among you. Lots of different business executives joining us today, and I could not be more excited for what we've got in front of us. So just a tiny little story. I got to see Felicia Hill-Briggs speak. I've actually been lucky enough to read about her talks many times, but I got to see her speak in something that was absolutely spellbinding on social determinants of health at the ADA in 2019. Martin Kurian, who was an associate back then, who's now in medical school at Penn, this was 88 postgrad, and we were just so blown away by her talk. And he just came over and said, I've never, ever heard such an amazing talk. And I've been to 24 conferences, I think at the time he had been to already. And everyone in the room felt absolutely the same. And that was when the scientific review of social determinants of health, she was in the middle of writing that. We got to hear her again at ADA, again at ADA postgrad in 2021. And I saw it, I emailed her, and she had just taken on this really, really, really cool new job. And she said, write me again in 6 months. And I tried to, and then the incredible Dr. Fran Kaufman wrote her, and then she said yes. So it's just thrilling that they're here. And I just, I just wanted to say the fact that, we get to, at Close Concerns, sort of bring what is this specialty of both of these leaders, not only all of their brain power, but like the energy, like how they make you feel. I'm so proud that we get to bring that. And again, it's Abbott, it's Insulet, it's Novo Nordisk who are helping us do this. So how grateful I am to these organizations, and again, for the resources big time, but also for really helping us create Wild. Also, as you might imagine, Karen Irwin, the great, thank you so much to her for her just continued work at Wild. She said yes the very first time that we asked her if she would help us run it. She runs the event company in DC. We also, this is so exciting, we're saying thank you to Linda Smith-Breckheisen. She is our brand new Research and Communications Deputy, and to 2 remarkable Dartmouth Fellows, Elaine Young and Anahita Kodali, who have prepared us incredibly well. And they're also at school taking classes full time as they do this. So I know how much value doesn't even begin to go into it, how I feel about our Close Concerns team. All of our associates, they've started us off on, Diabetes UK at the beginning of the week. They're going to Dr. Klonoff's hospital meeting, then they're going to the American College of Cardiology, then they're going to CMH, then they're going to CMHC, and I might be forgetting one, but they bring us brain power every single day, and they come to work at Wild. So I really am so appreciative just to be able to watch and see how we've grown since we started in, I guess it was late 2020. And so really Wild was created to kind of elevate and advance both emerging and established women leaders and their allies who are working in and around diabetes, prediabetes, and obesity. So we've designed the network with each of you in mind, and we're going to continue to evolve the programming based on your feedback. This programming today is because of all that we learned from you about how much more in many cases, and how much in some cases you just really, really wanted to experience more learning about health equity. And we thought, because Fran told me the minute that this scientific review that Dr. Hill-Briggs put together with a number of colleagues, she told me the second that it came out, and I just knew if we could make this afternoon happen, this early evening, it would be wonderful. Please, because this is from you guys that we have this, please say yes to answering this survey. You'll get that right at the just at the end of this program. So we would say as well, when we started digging in, because what I always do when I want to learn even more about something, I look to all of the experts. I look to the people who are doing the amazing research on this and the work on the ground in the community, and I would say, we ran through this gamut of emotions, right? It was guilt, it was outrage, the tragic ongoing health consequences that systemic inequity and racism bring to our world and especially to our country. We felt those things. And, we also felt ambition, we felt hope at being able to kind of be able to make individual and collective learning work and individual and collective needed changes. So WILD is first and foremost a community of leaders. Again, some of you are super experienced, some of you are emerging, but how do we navigate these issues that seem at the same time so broad, right? They're so broad and they're so deep. And so again, starting in at the beginning, looking at all the learning, I know that you only got the pre-reading a few days ago, but this is going to be really an amazing series of learnings that, again, I think will bring something to every single person, no matter what your experience is. So, I think it's really fair to say, for sure, for me, it's a lot of unlearning, and it's been the start of that. And we're gonna figure out what is our capacity to change. Okay, so this organization is really founded on principles of learning and connecting as essential tools for doing. And as Dan Pink reminds us, thinking is for doing. I really hope that you're inspired by our speakers and find within yourself the intention to join them in leading. And I'm going to tell you one thing, Dan is still on a plane. And so if he ends up being a little late, we don't know what kind of time American Airlines is going to make up, but if he is a little bit late, I'm going to tell you a little story about what I learned yesterday when I was in Chicago at a meeting about CGM, and just about what I saw, again, in the amazing capacity that we have to really move things, but it is a scientific renaissance and technology has never been this powerful. And I'll tell you a little bit about that. That meeting on Access AM, I think it's AMCP, but it might be AMPC. It's new to me, but very powerful. And I got to sit next to Dr. Monica Peak. So that in itself was really huge. And it brings me back to what we're doing here. She could not believe that we were going to get to hear Dr. Felicia Hill-Briggs today after an amazing tenure at Hopkins, which I mentioned before. I just quickly, there she was this extraordinary kind of thought leader, really known for her work in behavior and internal medicine, and in and around, of course, endocrinology, diabetes, and metabolism. She was running all these different NIH-funded projects. She's so modest, but the number of times she's been funded by NIH, which is as best as you can get, has been so many, and has brought so much teaching on these really, really serious, all these different serious studies. But then this health system called her Northwell Health. They were so lucky, you guys, because she said yes to being the named chair. That's a big deal. The named chair in clinical research there. And so I know that we're going to hear a little bit more about that from her, but it's incredible that she said yes, and she's going to be bringing to us expertise and kind of taking us through SDOH throughout her career as a research and as a practitioner, and especially in this multi-year project in writing this scientific review for diabetes care. And I can't even also tell you how amazingly deliberate this decision was by ADA to be able to make this work happen. So following her talk, then Dr. Fran Kaufman, our beloved faculty member, is going to be joining Felicia in conversation and in facilitating a conversation with Dr. Hill-Briggs. So mark your questions down. And then, like I said, we're going to be welcoming this best-selling author of one of the most anticipated books of 2022, Daniel H. Pink. And his new book is called The Power of Regret. And maybe you can put up like a little heart sign or a little thumbs up. You might have it already through being here. Thank you. We're sending it to you also. And if you already have it, then you can think about who to give it to. But this has been really interesting to think about. It's the power of regret, right? How looking backward moves us forward. I won't even go through all the places where that's been such a huge hit, but he's going to really talk to us about some valuable lessons he's learned. He put together a 20,000 person study on regret. So, I think, and I'm a groupie. I'll tell you, I'm a damn pink groupie. What he's going to talk about, some of it is just like how we can be kind of stalled in our actions because of something that's uncomfortable. Right. And we know that facing, the problems, all of the different challenges surrounding SDOH can really put us in uncomfortable situations. And we can't wait to hear what his wisdom is on this, again, to help us really drive to action within our personal lives or professional lives as members of the diabetes community. So the problems of social determinants of health, they live in the macro, we live in the micro. We hope that this year is going to provide you foundation for education and capacity for change, whether you're educating a colleague or a client over lunch, directing office-wide changes, navigating nationwide for reform, or being at a dinner table with your family, or not being at a dinner table with your family. There's so much here, and this is the groundwater, as Dr. Bob Babay talks about so eloquently, and Tracy Brown as well. So there's a lot of continuity coming from other work that all of you have supported here at Wild again. So grateful for the speaker's time, and I know that you'll take so much away from unique insights. Thank you so much for being here. Take it away, Dr. Felicia Hill-Briggs.
Well, Kelly, first let me say thank you for inviting me, and to Fran and to the entire Wild staff. As all of you on this Zoom know, I'm sure, Kelly is impossible to say no to. Kelly, your commitment, your passion are infectious. And so it really, truly is an honor to me that you invited me to come. And I can't tell you how enthusiastic I am about the fact that this is the topic that you all have selected as so important to be shared. So as I bring up my presentation, just give me a thumbs up. Let me know if you all are able to see this well. Okay, great. So as Kelly said, I'm going to be kicking off talking about social determinants of health, and really in the context of leading change, because I know that the folks who are on this Zoom are all people who lead, who have leadership roles in various ways within the diabetes ecosystem. And as you know, social determinants of health is critical to our future in diabetes and diabetes equity. So I'm going to go in somewhat of a reverse order today, because I want to challenge us to gain a deeper understanding of social determinants. And so I'm going to start actually with recommendations that guide the current social determinants of health work that is happening in many of our healthcare systems and that we're all familiar with. And then I want to push us to shift our understanding of social determinants. And here I will review some highlights of the ADA's scientific review, particularly definitions, but I want you to look at them in a different way. And then I'm going to illustrate social determinants of health using a population exemplar. And finally, Kelly was mentioning those issues of regret and uncomfortable things that we have to think about and deal with. That's where confronting root causes falls in for social determinants of health. And how do we face them? Because we can't solve problems that we won't face. And then how do we develop and use multi-sectoral leadership towards moving the nation as a whole forward on this issue? So as you all are aware, social determinants of health are definitely not new. However, it's probably been only over the last 8 to 10 years that the term has been used commonly in medicine and in health and in healthcare. And that really came with the shift in how we finance healthcare, moving away from fee-for-service towards more performance-based models, value-based care, population health, which meant that we couldn't only look at individual outcomes, we had to start looking at the population as a whole and could no longer overlook health inequities and disparities within our populations that we treat. And so social determinants of health rose to the forefront as an inroads for reducing health disparities. And several US agencies adopted very early on then the importance of taking a look at social determinants of health as a direction for us to start planning interventions. So CDC, the Department of Health and Human Services, Healthy People 2020 and 2030 have social determinants of health there. The Institute of Medicine, which is now the National Academies, Institute for Healthcare Improvement in their first population health model put health equity at the forefront. And they, of course, have continuously raised the issue of equity and social determinants and influences and factors. And even CMS as a payer included health equity as a part of long-term planning and is trying to figure out how the social determinants of health should be addressed even from their vantage point. So the World Health Organization was the first organization to commission a report on the social determinants of health and to develop and publish recommendations about how to address social determinants. Their report came out in 2008. It was later that the US convened and then subsequently published national reports about key features of how we're going to come to learn about and start to plan around social determinants of health here in this country. And here are three of the initial reports. The 2010 Capturing Social and Behavioral Domains and Measures in Electronic Health Records report. In 2016 and 17 were frameworks for how to educate healthcare professionals about social determinants of health. And then Institute of Medicine, now NAM, in 2019, published the Integrating Social Care into the Delivery of Healthcare report. And each of these came a bit closer to identifying very specific tasks, if you will, that were deemed important for healthcare as a sector to do in order to start to attend to social determinants and start intervening on them. The reports are very consistent in the overarching types of recommendations they yielded. 4 primary recommendations. The first is around standardizing data collection. We have to know what the prevalence of these social determinants are, whom it's impacting. We need to know, even at an individual level, who is experiencing and who is not experiencing social determinants. And many of you may be familiar with the CMS screening tool that has come from Accountable Health Communities model, and that now is actually getting integrated into several EMRs in the country as one standardized way to approach measurement. The second overarching recommendation yielded is around the training and teaching of health professionals, not only so that there can be increased awareness of social determinants, but so that social determinants can become an innate part of the mission of healthcare, the culture of healthcare, and the work that health professionals do. The third recommendation is all around how we integrate social care into routine health care, including not the measurement, but also the building of workforces to integrate the care, how we are able to identify sources of social care and how that integration gets financed. And then the fourth primary recommendation is around building that digital data infrastructure so that data can be captured, understood, monitored, evaluated, and exchanged. So CMMI, because there really had not been any large-scale studies in the United States regarding social determinants in terms of testing how to intervene on social determinants of health. There are a few models, a few examples that have happened, particularly early in the 1970s, but there have not been large-scale studies designed to know whether if we actually measure social determinants of health for individual people, and if we connect people with social services and care in order to address those, would we see improvements in health outcomes? Would we see reductions in disparities and inequities? Would we see improvements in healthcare value, costs, utilization? And so CMI set up its demonstration project, the Accountable Health Communities, in order to test originally 3 different questions, but they were able to combine those 3 into 2 primary tracks. The first is assistance, and there what's being tested is universal screening to Medicare and Medicaid beneficiaries in order to identify what they're calling social determinants in AHC model, health-related social needs. And there are 5 needs that are being screened for, and those are listed here: housing instability, food insecurity, transportation, utility, and interpersonal violence. And then after screening in the assistance track, each patient is provided navigation to community services to address those needs. The second track is alignment that does the universal screening. It provides navigation to community services, but it also involves engaging community stakeholders, organizations, in order not only to improve the quality of the social needs care, but also to help address and increase community service capacity in order to meet needs. And I don't know how many of you may have seen this model evaluation's first report. I think it came out at the end of December of 2020, but we were in the midst of COVID, and I don't think it got the attention that it normally would have. It actually won't end until April 2020, so this evaluation is still occurring. There are 29 participating organizations. 11 were testing assistance and 18 testing alignment. There were 3 additional participating organizations who voluntarily decided not to continue in this model demonstration. But the early findings are listed here. Beneficiaries who qualified for the intervention, and to qualify, you had to have 1 or more social need, and you had to have 2 or more emergency department visits within the year prior to getting your screening for your health-related social needs. So those people who met those criteria were, not surprisingly, disproportionately low income, racial and ethnic minorities, on Medicaid, and among the Medicare beneficiaries who qualified, they were the disabled beneficiaries. In addition, the majority of eligible folks for the intervention had multiple health-related social needs as opposed to 1 single need to be addressed. 75% of the eligible beneficiaries accepted navigation to community services, so people were very happy to receive services to get them where they needed to go, but only 14% of those who completed a full year of being navigated to services had any health-related social needs documented as resolved. And there were some improvements in healthcare utilization, but the evaluators concluded that at that early stage, they weren't able to attribute any changes in healthcare utilization to resolution of health-related social needs. There are many factors that may contribute to improved utilizations, including the fact that each person got interviewed in order to get the universal screening for health-related social needs. So time, attention, talking to healthcare providers may have contributed even themselves. And so in this early stage of interventions to address health equity, what you all have seen this cartoon. We started out with thinking that the goal should be equality, that everyone will benefit if they get the same thing. We are clearly in the era of equity, and we've been in this equity period for probably 2 decades now, where we have been testing and we've identified if you give different people the different supports they need in order to have access to care and outcomes, then we will likely get towards equity. And the way we are doing that has been through the things recommended in those reports. It's such things as integrating social needs care. It's such things as the referrals to community services. It's new workforces, such as community health workers and navigators. It's care management programs and special types of transition care that were developed in order to provide extra supports. The challenge has been that we certainly, at a population level in this country, or even regional level, have not been able to demonstrate reductions in disparities, whether it's diabetes or any other health condition. And I don't know how many of you remember back in the 1990s when community health worker interventions were really coming into the forefront. And that was a large proportion of types of interventions NIH was starting to fund. It was a brand new model of care. Those studies showed that having community health workers present was very helpful for helping people access care that they needed and access other resources that they needed. However, when the study ended, community health workers went away, and then everyone returned to baseline when the intervention was removed. And so initially there was a lot of backlash actually against community health worker interventions because communities loved them, but then complained that when the research ended, all of that was taken away. And so a challenge still with these equity extra support interventions is how can we ensure what is needed gets sustained if this is the model we're intervening upon? And there are solutions to that. And of course, there are states who do reimburse, and community health workers are deemed a part of a healthcare workforce. There are many new ways that community health workers have been able to be built into routine care within many healthcare systems here in the US, not all, but many. But in some, when we evaluate where we have been so far with interventions to address social determinants of health, or how we're approaching it here, these interventions and our framework for how we intervene really has originated within the healthcare sector. And many of the interventions are focused at the level of the individual. They feature measurement, they feature referral interventions. They necessarily have had to treat social determinants often as transient or independent, what a referral for a particular need, or a one-time referral for transportation, but not transportation for the rest of life, for example. And in most communities, the referral back to community services is reliant upon the availability of these resources in low resource communities. And very often the community-based organizations are nonprofit organizations that are dependent upon donations and are run by the very same underrepresented groups that are in need of the services. And so that question of how can we ensure adequacy of resources to keep referring people right back to their communities has been an important one, and one that has not been solved. And so I want us, in light of where we've gotten so far in, I think there was a real haste to want to do something about social determinants of health once it became understood that these really are impacting outcomes, populations, and also harming healthcare systems and hospitals in terms of reimbursement and things of that nature. So I'm going to now kind of go through some of the basic definitions again, the standard definitions of social determinants, but I really want you to look at it with a different eye, and I'll kind of guide you through that. So as Kelly mentioned, the ADA Social Determinants of Health review was conducted by a committee that was put together by ADA of experts around the country, and that paper was published in 2020. In that paper, we really did attempt to put all of the key definitions and to frame it in as comprehensive a way as possible, because that did not yet exist. And so let's just take a look at the definition of social determinants of health. And this is the World Health Organization, which is the most commonly used one still. Social determinants of health are the conditions in which people are born, grow, work, live, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries. Two related terms that we use very frequently are health disparities. And as you look at these, I want you to hopefully feel the gravity of the definitions. A type of difference in health that is closely linked with social or economic disadvantage. Health disparities negatively affect groups of people who have systematically experienced greater social or economic obstacles. These obstacles stem from characteristics historically linked to discrimination or exclusion, such as race or ethnicity, religion, socioeconomic status, gender, mental health, sexual orientation, geographic location, and most recently, cognitive, sensory, and physical disabilities have been added. And health equity, the absence of avoidable, unfair, or remediable differences among groups of people, irrespective of their social, economic, demographic, geographical, or other stratification. And so when we talk about health equity, what we really mean is that ideally everyone should have that fair opportunity to attain their full health potential, and that social determinants are the state of people not being given a fair opportunity to attain their full health potential. And so in the setting of health disparities, which is where we continue to dwell right now, it is through understanding and intervening on social determinants of health that we can achieve greater health equity, but we can't do it without addressing social determinants. And so what do we mean by social determinants? There is no consensus definition for what is and is not a social determinant. There's no consensus that there are 5 or 10 social determinants, for example. However, each of the prominent frameworks on social determinants of health have largely similar factors identified. And this figure from the ADA review shows the 4 primary frameworks for social determinants of health that we reviewed and then identified the sets that we would include in the review. Note that the World Health Organization starts somewhere so the World Health Organization is first. The other three are all US-based organizations and frameworks. The World Health Organization starts at a place before the US models. And so what they all have in common is things such as your socioeconomic position, your economic stability, economic factors, and then social factors, built environment, neighborhood, health, the food environment, and health systems. But that first box for the World Health Organization talks about the social and political context, which includes governance and the structure of government, policies, social policies, your labor and housing policies, public policies, education, health, cultural and societal values. Whereas the US models start more with individual level factors, but not more upstream, US contextual factors. Notice also under the social, I'll say a bit more about the social one in a moment. And so for the ADA review, there were 4 overarching social determinants of health that we selected from those models, those frameworks, and then each has component factors. And for those who've had a chance to take a look at the review, we reviewed evidence with regard to diabetes for each of these social determinants and their component factors. There's too much to be able to summarize all of the findings here today. The report itself is very detailed, intentionally, very thorough. And so I would encourage you to take a look, particularly at particular social determinants you may have a special interest in order to see in what ways the research demonstrates their associations with diabetes. But I can summarize here by saying that each of the social determinants of health have associations established in the literature with diabetes incidence and or prevalence and or morbidity and or mortality. And so diabetes becomes a really nice exemplar disease for demonstrating social determinants of health. I think amongst these 5 and their component factors, these are generally things that we are all now familiar with. It's important to note that for socioeconomic status, all 3, education, income, and occupational status, have individual contributions to one's overall socioeconomic status, but the 3 collectively are needed to define SES. In healthcare, for example, having health insurance is the strongest predictor of whether or not people receive diabetes-related screenings or care. Health insurance is critical, so the access factor, but it also includes such things as geographical access. We know that endocrinologists and diabetes educators are concentrated in higher socioeconomic status neighborhoods, with far fewer in rural areas and in low income environments. So those are also access factors. And under social context, these are the first 2 are terms that we don't use so much in the US. And I think many in healthcare have not heard the terms used in a health context, although social science uses them. So I just want to read for a minute what social cohesion, social capital mean, because this is again where we start to think beyond our current understanding. So social cohesion is the degree of connectedness and solidarity among groups in a society, and inclusivity versus marginalization of groups. So this is where racism, for example, fits in. And the World Health Organization lists racism specifically as a social determinant. Social capital is features of social structures that serve as resources for collective action, resources for interpersonal trust, reciprocity norms, mutual aid, and individual agency, what agency people and groups have within a society. Those are two areas that we could not find much research on, not surprisingly, with regard to diabetes. Social support, we do a great deal of research on here in the US, of course. So there are still some areas for us to look more deeply, but those would be getting us, and they would be getting us closer to some root cause issues we have here. So now I'm going to walk you through just some illustrations, again, to encourage a deeper understanding of where we're going to need to move in terms of intervening. As we all know, diabetes has persisting disparities by race and ethnicity. We also know that each year when the National Diabetes Statistics Report comes out, the numbers may have shifted slightly, but the patterns remain. Diabetes prevalence is more prevalent the less education you have. It's clearly split by whether you have a terminal high school diploma or less than high school education or more than high school education. And Braverman and colleagues did a great study that's starting to get old now, but the patterns remain the same, where they looked at income and race, because we know that those two are heavily confounded, to demonstrate that, yes, diabetes prevalence increases with higher levels of poverty. These bars are in percentage below the federal poverty level, and that pattern holds across racial and ethnic groups. So it's not only race ethnicity that drives income disparities in diabetes prevalence. And just before the pandemic, CDC put out its latest report on diabetes incidence and prevalence, and they concluded that after that 20 years of increasing incidence, increasing prevalence and incidence, they'd identified an 8-year period of stability in prevalence and starting to turn the tide and see a decrease in incidence rates. But as not surprisingly, we did not see those patterns for people with lower education and people in racial and ethnic minority groups. So here, this is incidence of diabetes by education. And of course, those with less than a high school education not only did not decrease in incidence rates, but are still having slightly increasing incidence rates. And the two bars at the very top, almost overlapping for race ethnicity, are Blacks and Hispanics. Whereas non-Hispanic whites in red there and Asians are seeing a decreased incidence in diabetes. We are not seeing that pattern in Hispanics or Blacks. So again, the disparities that have been there do persist and largely driven by social determinants. So what's important to recognize is that social determinants are cyclical. They are systemic, therefore they are intergenerational. And so solutions, of course, are not easy to come by. One's education and educational opportunities determine one's occupational opportunities and occupational status. Occupational status determines income. Income determines many access points, such as your neighborhood, what neighborhood you can live in, what's available in your physical environment, the quality of health care you have access to. All of those things also then in turn can affect things such as your educational opportunities. And for education, we're talking not only about quantity, but quality of education, which is measured as literacy. And you all likely remember it was in the early 2000s where literacy really became a focus of funding and intervention because of the finding that lower health literacy was associated with almost every disease and every disease outcome. And that's because it's a proxy for education. Occupational status, we're talking about employment status and job classification, household income, poverty status, and these. And so The fact that each influences the other and determines opportunities means that at a population level, there's not just one point of entry that's needed in order to address and see improvements in social determinants. So as a compendium to the ADA's scientific review, colleagues and I published this paper. Came out in January, that is looking at African Americans as one population exemplar for how the social determinants of health are embedded. And you can do this with any other racial or ethnic minority group in the US as well. There are different factors and historic factors that have contributed, but we can trace back root contributors, historical contributors, root causes. So for education, for example, African Americans are continuing to gain ground in terms of having access to high school education and completing a high school education. So we're almost on par with whites. You see disparities more, of course, with bachelor's degree and advanced degrees. Although Blacks now have access to education, the quality of education is what differs dramatically. And this is where you see differences in literacy rates, the quality of education. And of course, it's not surprising that there are differences in educational attainment, because in the United States, it was illegal for African Americans to receive an education, to read or to write, or to gather for the purpose of learning to read or write under penalty of death. And the US state anti-literacy laws persisted early into the 1900s. I'm from Maryland. My family was from Maryland and Virginia, heavy slave states. And so it was illegal for my grandparents to receive an education in the United States. During their early childhood and up through teenagehood, it was still illegal for them to be educated. And of course, my parents grew up when it was no longer illegal for them to be educated, but it was illegal for them to attend public schools with white children. And so in Baltimore, where there was just, for example, 2 schools that Black children could attend, children as young as 5, Black children as young as 5, had to go to school in the evening, take buses, public transportation at night to go to one of the 2 Black segregated schools in Baltimore City. I am first generation, and I'm not that old. So when we say this is a long time ago, I'm first generation able to attend public school in the United States legally with white children. And I was 9 when I went from my all segregated school in Baltimore to an integrated school in Baltimore County. So this is not ancient history. Occupational status. Well, of course, education determines occupational opportunities. So unemployment rates have always been much higher for African Americans as compared to whites in this country, but the gap is narrowing. Upon emancipation from slavery, there was almost a 99% unemployment rate for African Americans, because due to Jim Crow laws, it was still illegal to hire African Americans to paying jobs. And so we still see differences in unemployment rates, but these are very tiny gaps compared to where we started in this country after slavery. And so if you look at types of job status, you'll find that for African Americans, still fewer numbers are in management occupations than are in service jobs such as janitors or baggage porters or bellhops. And it will still take a while before Blacks are able to move from the service level positions in this country to higher types of job status. So that impacts your income, obviously. Means of transportation to work. Many African Americans, a larger percentage of African Americans are dependent upon public transportation, and fewer have vehicles at home. When we look at income, yes, what we would expect, median household income is much lower for African Americans than for whites. Among persons living 25% of African Americans, so 1 in 4 African Americans lives 125% below the poverty line. Let me say that one more time. Despite the advances that we tend to see and celebrate in the United States, 1 in 4 African Americans is living 125% below the poverty line. Wealth has not yet been able to start accumulating in African Americans as a population because, again, we started with 0 upon emancipation from slavery due to hundreds of years of work with no pay. And although in the US, we're much more aware now of gender inequity in pay, we know that women are paid less than men for equal work. I think we're less cognizant of the fact that we also have racial inequities in pay. So African Americans are paid less than white Americans for the same jobs. And so African American women, so for example, white women are paid 82 cents on the dollar that white men are paid. African American women are paid 63 cents on the dollar. And similar to income, in terms of where people live, we are living in different places in this country. So again, 1 in 4 African Americans is living in extreme poverty. Census tracts, disparities in home ownership rates, mortgage application rates, and denial rates. Among the homeless population, more than 1 in 3 is African American. Now, African Americans comprise 12 to 13% of the US population, but we comprise more than 39% of those who are homeless. And among homeless families with children, more than half are African American. And so when we look at social determinants and the cyclical nature of them, it's not surprising that health inequities are ubiquitous. It's not just diabetes, as we know, it's almost any disease you can think of. And of course, it was COVID-19 as well. You're going to see the same outcomes because we have the exact same inputs. So now let me talk about the uncomfortable things, confronting root causes. And I apologize because I'm looking at the clock and I see I'm talking a little bit more, so I may run over a bit in the presentation part. You all let me know if it's okay if I continue a little bit over in the presentation part. Okay, so as I mentioned, we went from equality and we're firmly in the phase of equity. What if we moved to a next phase, root cause barrier removal? So here, instead of building more supports, resources, more workforces, more case managers, more social needs referrals, what if we were actually able to remove the inequity, remove the systemic barrier so that everyone has access without trying to accommodate or get over the barriers? What does that look like? So, there we go. The World Health Organization in 2008 recommended the following. They recommended barrier removal. And these are their 3 primary recommended actions: improve daily living conditions. And they focus on early childhood education and development. Number 2, tackle the inequitable distribution of power, money, and resources. Number 3, measure and understand the problem and address the impact of action. And so when you have a chance, if you can take a look at that original 2008 report and what the World Health Organization has set up by way of supports to help countries interested in doing this type of root cause work, there are inroads that are proposed and that can be made. Here in the US, most of our recommendations have been more transactional to date. but we are now moving towards something that comes closer to the World Health Organization's recommendations, and that's called Health in All Policies. It's a collaborative approach which really focuses on the fact that health is influenced by these social determinants, and therefore in any and every policy that is being set in the United States, we really need to think about what impact it's going to have on health. So if you're building a low income housing or a mixed income housing, maybe there should be a policy for zoning that includes access to food instead of zoning that prohibits access to food or food establishments being in the same neighborhood, for example. The National Clinical Care Commission was established nationally for the purpose of reporting to Congress on what can be done about diabetes and its complications. And this is a fascinating report. It came out in December of just this past year and deserves reading. It's very long, but what is so remarkable to me about it, I think it's the first of its kind in this country, is that, and this is from the executive summary, it concludes that the social and environmental conditions that shape people's daily experiences have a huge impact on whether people develop diabetes and suffer from its consequences. And they stated that it's clear that if we really are going to deal with diabetes in this country effectively, we cannot view it or treat it as simply a medical or health problem, but it has to be treated as a societal problem. And so again, here diabetes is being used as an exemplar. If we can tackle it in diabetes, if we can set up what's recommended in diabetes, of course, it would help not just diabetes, it would help all of health. And so I've pulled just a few of the recommendations from this report to show you the flavor of them. So they're recommending health equity be a component of all federal policies and programs. CMS in February, released had press releases saying that as they redesign accountable care organizations, they are including and will start requiring a health equity component as an example. But it also means other sectors must think about health and equity in their policy setting. So this one is another fascinating report. They're recommending creating a national, an Office of National Diabetes Policy to develop and implement a national diabetes strategy that leverages and coordinates work across federal agencies and departments to change social and environmental conditions promoting the type 2 diabetes epidemic. And just take a look below at the types of departments and agencies. These were all represented in this NCCC report and committee. And this is the extent to which they are saying that everyone has to be at the table if we are going to improve diabetes outcomes. The Department of Agriculture, the Federal Bureau of Prisons, all of these people have to be at the table because policies need to be able to positively change these social and environmental conditions. And this is where we're really talking about a different type of multi-sectoral leadership for a health outcome. And I've included just one of the research recommendations. They are saying that we have to do different research to solve this problem. This is not a 5-year randomized clinical trial, although you could design one to look at some of these issues, but what we need is research that brings evidence that's related to social and environmental policies, research that will inform what those policies should look like, research that determines whether these policies are now promoting more inequity inadvertently, whether policies are now set in a way that we can hope to see decreased inequities. NIDDK has set up a Health Disparities and Health Equity Advisory Council. I'm a member of this council. It is really just getting underway, but there are 4 preliminary questions the research members of the council have been asked to examine. And the purpose is to help NIDDK determine what types of research and key questions need to be addressed specifically about social determinants of health in order to move towards the types of research that's being recommended by groups such as NCCC. There is a recognition that we have to do this differently, even as researchers. And I'll end by talking about racism a bit as a root cause. Very uncomfortable topic for the United States. So uncomfortable that, legislation to prevent it from being taught in US schools, and it isn't taught in many US schools. It's not in curricula because of how uncomfortable it is. And even just the history of the facts of history have been deemed too uncomfortable for Americans to learn about. And so it's really important when health and public health are saying what we have to put racism on the table, because if we don't, we really cannot solve the big problems. So these are just some examples of our health agencies that have put racism on the table. CDC, the American Public Health Association, they in fact have resolutions and declarations, and public health departments in several states have written these declarations stating that racism is a public health crisis in the US. I don't know how many of you are aware that the American Psychological Association in October of this past year published 2 very, very strong statements. The first is, and these are the titles: Apology to People of Color for APA's Role in Promoting, Perpetuating, and Failing to Challenge Racism, Racial Discrimination, and Human Hierarchy in the US. And in their resolution to advance health equity in psychology, talk specifically about what the aftermath has been of racism and complicity in racism in this country, and the fact that that's something at some point we as a country have to address and acknowledge in order to move forward if we really have intentions of improving equity. And so, in summary, what I hope you've gotten out of this is a few points. That first, social determinants of health are population-based, they are systemic, they are cyclical, and they are intergenerational, as opposed to originating at an individual level as transient or an isolated phenomenon. Social determinants of health is not here's someone who's down on their luck right now. That's not the social determinants of health. Number 2, current approaches to addressing social determinants of health that focus on individual level measurement and referral to community and social services are necessary at the present time because we don't have a great deal else. But it's important that we also recognize that these approaches are inadequate for changing the conditions in which populations live. And that's one reason why we're not yet able to mitigate these inequities at population levels, no matter how many referrals we make. Evolution to systemic interventions that recognize and address root causes is essential and urgently needed. And such interventions will require, at the very least, that health and all policies approach and perspective and multi-sector collaboration towards a common good, and that's the health and well-being of the nation as a whole. And I'll just leave these questions here because as leaders, things to think about are the ones listed here. Where does your company or organization sit in the diabetes ecosystem? And what's the history of your sector in terms of issues of equity? And what social determinant of health barriers are in the way for your organization's work? and what policies and regulations stand in the way, and what's within your purview to influence or impact. Thank you.
Felicia, that was phenomenal. I took copious notes, and there's so much to digest, and I'm just sure there are a myriad of questions for you. So you're already getting the chat a number of accolades and appreciation for all that you have stated today. I mean, you know, I read avidly when your piece came out and thought it was transformative. You know, although I am in part in industry, I'm still a healthcare provider. And I just think in my own clinic, you know, we have a 10 to 15 minute grace period for people showing up to appointments late, which is so insane, right?
Yep.
So those are the kind of things that I think all of us need to examine and, you know, put in the context of the way our patients lead their lives. And a lot of it is not voluntary.
That's right.
That's for sure.
Yes.
So I do have, let me start if I, as a moderator, maybe have the first question. And I am a member of the National Academy of Medicine. So just wondering, you know, those 4 recommendations, which I remember so well, how have they played out? Do you really think this is something that has come to Main Street, Main Hospital, the medical center?
Yes, I think many of them have. So certainly, I think across the country, health systems are aware that measuring, for example, social determinants of health is something that can be beneficial to do. And at conferences and healthcare conferences or like payer conferences, there's a lot of discussion and questions around, well, how should we measure it? At what level should we measure it? Do we do it with everyone? But they're asking questions around trying to adopt the concept that we have to at some point interact with patients and find out in a more systematic way whether or not they're experiencing this, as opposed to just, you know, a person who's homeless did show up in the ED today, but how amongst our populations do we actually do it? And we know that, you know, electronic medical record systems out there built their own social determinant of health questions and wheels and ways to display it visually. And so I'd say there definitely has been responsiveness to it needs to be measured. The problem, I'd say, is that because there had not been, at the time people started to measure, and at the time the products were made to measure, there had not been an understanding of what do we mean by social determinant. So a lot of what we're doing is still trying to tease behaviors out of the social determinants, one, because different workforces need to ask different types of questions, you know, questions to, you know, screen for depression when they are a part of a social determinant of health evaluation. No, there are specific people who should be asking about depression and going through those clinical questions. And you can't just, you know, refer to a community resource for it. And so being able to make sure there's an understanding at the level of the health system, what's a social determinant of health, what is not, what workforce needs to be available to ask those questions, ensuring then there is some way to follow up, which there just isn't in, I'd say, most cases currently within health systems. But then, of course, there are companies that, you know, are now working very hard on building the community infrastructure and the data systems to communicate back and forth and make referrals. But what the investment hasn't been made in, what are we referring them to? Yeah. Where are we sending them? Yes, maybe we can help them with making rent this month, but what about next month? Yeah.
Yeah, no, I agree. And, you know, I am a pediatric endocrinologist, and I feel that, you know, the measures really, some of them need to be quite different in my population. It's at the teen level, a lot going on interpersonally, and at the family level. And, you know, we are asking more and more questions, doing more and more screening, making a lot of referrals in the EMR, and where they go from there. I mean, it's very easy to refer everything in the EMR.
Very easy to press that referral button. It really
Right.
is. But that's
And-
what's being measured. So that's, mhm.
Right, and then the follow-up of all of that, but it's the beginning. And
It
it's
is a
certainly-
beginning. So that's an adoption. I'd say the other thing that has happened is with that measurement, and just as you're saying, that third report on integrating social needs care. I mean, that's happening, right? They're trying to find referral sources, but we don't have a national system or way of financing and building then what's needed in order to actually get people what they need. And we still, and when we're doing on an individual level, yes, by definition, you end up having to treat these as isolated and transient things that people are going through, as opposed to, well, how do we make sure that, this patient has a place to live today, but also 3 months from now still has a place to live, and a year from now has a way of having income, has a place to house their children. No one's asking those questions. We can get them something maybe for today.
Yeah. We do have a question from my friend Jennifer Hone. So I don't know, there she is. She's got her hand up. So
Hey, Fran,
and you're
thank you.
unmuted, Jennifer.
Thanks a lot. I had a couple of questions. First of all, just as a follow-up or continuation of this most recent conversation about asking the questions, I think your comment about what's happening with EMRs is very interesting. And one of the problems that really needs to be addressed federally is the concept of standardization. I know Kevin Larson, who used to be with CMMI, who's now with United Health Group, is working really hard with a whole group to come up with standardization of language so that you can actually measure across systems to ask, if everybody's asking the question differently, you don't even know if those answers are comparable, which is an incredibly difficult problem, I think, to solve, and incredibly important, and has to happen at a national level as opposed to one-offs, which is what's happening now. And as for the real question I had, which is around the idea of who should be helping to develop these really local and important social structures and organizations, community CBOs, to help deliver these services. I feel like you look at other countries and we all talk about the cost of healthcare in America compared to the cost of healthcare across the borders. And the difference, a big difference, is the amount of money and resources spent on social safety nets in these other countries, which then drives health outcomes and health costs. So I think we have to ask as a country, who's benefiting from this investment in social organizations? Because if it's healthcare insurance companies who are getting the benefit of people having access to these services, then by God, they should pay for them. On the other hand, if we're going to think in a more socially connected way, maybe it makes more sense for these to be more, again, standardized and consistent and locally individualized on some level, but at the same time, not dependent on this sort of frantic drive for contributions from individuals, which makes them unstable and unsustainable.
Yes, excellent points. And this question of ownership is very real. And they are likely, so for example, in this NCCC report, where they recommend an Office of National Diabetes Strategy, that's a level at which even a question of ownership would have to get discussed. Only, what we actually need is an Office of National Social Determinants Strategy, right?
Yes.
It's just fascinating to me that it's happening within diabetes, but it's almost as though you have to slip things under the radar. And so by saying we're just thinking about diabetes, because diabetes, we really make strong arguments in policy about why diabetes is so important, and it is. And we have a congressional diabetes committee. I mean, we have lawmakers who are supposed to be thinking about diabetes and what needs to happen with diabetes. So I think it makes it, again, a wonderful example to use. But clearly what's needed is that Office of National Social Determinants, Social Needs Strategy, but that's very antithetical to United States culture. This is not a culture that says that healthcare is a right. It is not a right. Healthcare is a privilege in this country. If you acknowledge that there is some need for a national committee to come together and solve this problem for everyone, for all, for the population, it is a cultural shift, and one that's very difficult right now to get national buy-in that, yeah, acknowledging that someone should take ownership of these issues. I think that's a hard sell in the United States.
No, it's a really hard sell. And I wonder if a national right to health or the opportunity to pursue health is part of the pursuit of happiness and all that. And so pursuing health might be a way to reframe that in terms of rights versus privileges. That helps people shift a little bit in that direction. And then, of course, the financial, since this country is run by money, much to my little socialist distress, there should be a way to make the financial argument. And it should be driven by policy to insist that those, again, who benefit from these investments understand the social return on investment, the SROI, not just the ROI. And it cannot be limited to within your savings. It has to be thought of as a long-term investment. To your point, if they only give housing for 3 months, if they only figure out how to get food to a person, I mean, what are they supposed to do afterwards?
Correct. And that's what happens.
Right.
So what everything that you are saying is exactly the thought leadership that is needed. The thought leadership.
100%.
So health is a part of the pursuit of happiness.
You like that, huh?
Reframing is there, but this is the type of thinking that's needed. It's understanding the American culture set of ideals and what's not included in American ideals, and seeing where and how we can fit this thing that we really think is very important. And goodness knows, healthcare costs are telling us it's very important. Again, to money does. How then do we start this shift to socialize some of these concepts, but within a way America can hear it and accept it?
Has to be a win-win, right? Otherwise, it'll never fly. Thank you very much. Appreciate it.
And unfortunately, now even a greater challenge: can America hear anything?
Correct. Unfortunately.
Ain't that the truth?
So we have a number of other questions. Lori Bamberger, how are you?
Great. Thank you so much, Dr. Hill-Briggs and Fran, for having this setting. I fundamentally think that the social determinants of health is probably one of the most pivotal things in national policy possible, and so few people get that. I work in, after having had an amazing experience with WILD and the awesome close concerns previously, I work again in national policy around housing, economic development, and innovation and industry clusters. And I guess I have some questions, and I have just some comments, and maybe we could do this offline later if you think they might be helpful. But I've always been coming from, I worked in the administration at HUD and a million years ago, in Clinton administration, and similarly in the Newsom administration in the city of San Francisco, around housing, community, and economic development. And I'm very much a proponent of place-based strategies as opposed to individual strategies, like welfare and entitlements are individual, and healthcare is an individual doctor-patient relationship. And yet, when we think of low-income communities, it is often a place. And
Yes.
I'm wondering whether, you know, this national policy can piggyback on some of the placemaking approaches, first of all. And then secondly, my question to you is, in the world I'm working in, economic development, we're kind of giving up on new national legislation and focusing again, sadly, on state and local, because things are possible in state and local governments that aren't in this debate. And I'm wondering whether your work is that also. And I'd be happy, for example, to make introductions to the Conference of Mayors. So this could be, they could be the champion locally, as opposed to trying to get HUD and HHS and Department of Energy and Department of Transportation to agree. They'll take 10 years on maybe including fresh food as a requirement of any federal housing funding, for example. But I'd be happy to figure out how to do it. I do recommend thinking about the funding that's going out today, ARPA funding, infrastructure funding, as a way to get really fast action. And anyway, that's my question: state, local, and place-based versus individual.
Yes, 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 and yes.
Okay, great.
Definitely place-based, because there you can build in the sustainability and a greater level of comprehensiveness. We are spending so much money and so much energy on these one-off, one-time, one person for just this 5-minute period things that people are exhausted, yet nothing has changed, unfortunately. And if you go back and talk to the person who got that one-off, one-time, they're like, well, I'm very happy that someone was willing to try to help me with that, but I'm still in that same situation today. And so it's not making sense. It's not making sense at any level. So yes, place-based strategies, definitely, if a state or local level is able to move, then we would want to use that movement and be able to use that as a model. Let's look at how they did it, why they did it, what happened with it, because chances are there can be another state that would like to see that thing happen. And so if one was able to make some movement, maybe that can help influence others to make a movement. I'd say while that's happening, though, at that national level, these larger agencies at some point would, though, need to come together at the very least, I believe, to reach some understanding, either an understanding that these things do influence health, or an understanding that, this is very hopeful, these things are important, and an understanding that what we're doing right now certainly isn't helping, but we're spending a hell of a lot of money on it. If they could come to an understanding that this is a problem that has no solution right now, but there are, at the local level, these folks, these people, these groups, these models really invested in doing that work to help figure it out, at least support and do not put up barriers at the national level to stop those people in, groups, organizations, local governments who actually want to try to jump in and do this work. And what the local and what the state levels will have available to them, can have available to them, is the research community who is so passionate about this, that has had the frustration of not having ways to go out and do this in the way it needs to be done because it doesn't fit a 5-year randomized award.
That's really, it's really valid. I guess you probably know about.
Sorry, hey, Lori, we're going to jump in and.
So let's definitely, Lori, talk more.
Yeah, you guys, we'll make a match here. Felicia, my understanding is you need to go. I know there's a couple more questions. You have time for maybe one more from Marissa?
Yeah, let me take one more.
Sorry, I can be quick. Thank you. It is such a joy to hear you speak. Hi, Felicia. Every time I hear you speak, I learn so much new. So thank you for your time. I know it's valuable. I asked this question because this conversation is both inspiring me to ask this question, but I'm here in Texas. It is hard for me to believe that advocacy does much. It is hard for me to believe that I can get my state and local leaders to do anything, or my federal leaders. Like I feel stuck by that. And I'm in a research position where I'm generating data about diabetes. And so my question for you is, what can I, as a researcher, or can we, those of us who are in this kind of position, what data might work, might be helpful? Like, are we, like, is it even worth getting data at this point? Or is that not the way to make these changes? Any just thoughts or advice you have about how to help in this kind of position, recognizing the limited listening skills that some of our leaders have?
Yep. Yeah, it's a great question. I think no matter where people sit, this is a huge problem, huge undertaking. There is not a clear next step. Oh, this is what I do now, and that's going to help get us somewhere. I would say first, do not lose hope, because we know that nothing will ever get better and things will get worse if those who think and care about these things lose hope, because then there's nothing, there's no one left. So I'd say don't lose hope. You can feel burned out and take a break and, sit, because you have to, but try not to lose hope, because all change takes a tremendous amount of time. You think about the hundreds of years that got us to where we are right now. This is not something that's going to reverse in the United States soon. It's just not going to. But that doesn't mean that we are not critical to the process of planting the seeds so that sometime in the future, something can happen. I do take, in my own mind, because I think about this all the time, just the weight of things, but I firmly believe that those of us who are here in this moment in time have tremendous opportunity, because the discussions are just starting. These discussions could not happen 10 years ago. They weren't happening, but we are all here while it's starting. I think we have a role in not letting the discussions stop, because what's going to happen is at some point, health systems are going to get fed up with this threat about you have to measure it. And the issues of it being non-standardized, there's no real workforce or set of people to do it, is going to make them say, what's the point? Just like many other things that have been recommended that then just fell off the table because it was hard. So I think we're important in not letting these discussions stop because of the challenges. We are still important in bringing data to the table, but making sure that we're using those data in constructive ways. Write a paper that you're going to send to Health Affairs. Write an op-ed. I wrote my first op-ed this year, and it was about social determinants, and it got published in US News and World Report. Start trying to find ways as researchers to get to other audiences. And again, you'd be surprised at what people just don't know. Some of lack of movement is there's no will or interest, but a lot of it is people just don't know. So we are holders of knowledge that the general public just doesn't even know. So how do we help to get that knowledge out there? Because in doing so, we do bring more people into the cause. And little seeds planted today can result in some actions being able to be taken down the road. This NCCC report could not have gotten published even 5 years ago. How dare they say things like this? How dare they? Representing government agencies saying things like this. How dare they? And I'd say let's jump on. When people are bold enough to put stuff out here like this, let's use it. Let's cite it. Let's use it as justification for what we put in our research grants. Talk it up everywhere you go. Let's get behind these agency representatives who said, we actually need to come together and have an Office of National Strategy on this. We said, we agree.
Felicia, I know that you don't even have time to listen to our thanks because you're moving on to your next gathering meeting commitment. We cannot begin to express, as Fran said, how incredibly motivating and how much we've learned. And there's so much. I can see that hand scribbling and typing all over. We will be back to you very, very soon to show just some of the impact of you being here. And I can't even begin to thank you.
Yeah.
you all so much. Again, it really is a pleasure. So thank you for having me. Anytime I can be available to do so, I'm always happy to be with you.
Oh my gosh.
Thank you so much.
Bye, everyone. Thanks.
Bye-bye.
Now this is amazing. We get to spend a couple of minutes getting reactions. The great Holly McGarraugh and the great Dr. Fran Kaufman. I mean, I'm dying to know what you both think. I know also Anna Norton had a question, if she's still here, about tech, and so maybe she'll put that in the chat, or we can go to her. But I mean, as you said, Fran, wow.
Yeah, I mean, it's, as a healthcare provider, I mean, there's so much to do. We've come some way, but this is the beginning of this now taught during training, this becoming a message, and that's where your chance of bringing it forward is, taking old people like me and making them change. I mean, the EMR, half my colleagues just quit medicine as soon as they brought that out. So I think if you start with a lot of surveys, but starting with all the trainees is really the right time. But there's just so much to be done. And, you look at the national political landscape and, it just seems so dismal where states are trying to get more rights. So maybe we do need to stay with governors and get whatever states we can to do more, and eventually come back as a federal policy when things calm down in the world a little bit. But there's no way to give up on this. I mean, this has got to happen. This has got to be the focus of all of our efforts collectively, and across the spectrum, and certainly inside industry. I mean, this is an ample thing for all of us as leaderships in our industry partners to really focus on, and how can we, within our own organizations and what we offer to people with diabetes, be able, start to think about doing. And maybe we should have our own little thought group ourselves with some individuals and come up with a bit of a policy for industry.
Yeah, I was really struck by the fact with the enormity of the size of this issue, and that we're still dealing with in the United States at things at an individual level. And that what was unique about the United States versus the rest of the world is that they're recognizing that the issues really are at a national level, policy level, and we don't even start looking at things until it comes to really more of a much more individual or lower system. So, we've got this big gap. And I think as individuals and then as we have leadership groups like this, we can start to make a difference, and we can start to push at policy and leadership levels up. And then we do everything that we can to push out and then keep on the individual. But we've got a big problem here.
Yeah, I mean, our country of the rugged individual and, all of our individual rights versus, you're right, Holly. I mean, the rest of the world is really about collective rights.
Right.
And we've never faced that. And I'm not sure this group can change that in any way, but we can certainly start to see, from our places of power. And, we are all, fortunately have some ability to affect change within our own organizations.
Yeah.
We should try to maybe come with a concerted, what would be next steps that we could all do potentially together.
Yeah. I think that that's where real change happens in the United States, is when concerned groups of individuals start to work upward for policy change.
I think we're so excited to say that Dan Pink is in the house, and
yay.
can't wait to see some of what
There
he,
he is.
everybody
Just glad to
literally
be anywhere, Dan.
just off the plane. That's some background. Holly, back to you and Dan.
Yeah. As we just had Dan, welcome. We just had a terrific discussion, presentation by Dr. Hill-Briggs, and she argued for a multi-sectorial change, and by its nature, it requires leadership and action from many, many people, all of us. And that really means that there are these obstacles to action in this arena, and that it's inherently difficult for us to be talking about these structural inequities and systemic racism. And so one of the things that we're sort of dealing with, as I know, as individuals, is how do we have these discussions without getting swallowed up by the reactions to past injustices? How can we move forward positively and without reactions to these injustices and historical wrongs? So that's why we are just so grateful to you being here today to talk about how we improve the future when there are so many of us that are stuck at the table, and about the mistakes of the past. So I'm very honored to be able to introduce you, best-selling author, thought leader, joining us today. And I get to hold up your book, if I do this right. There we go.
Well done.
I have to trick the technology.
Yeah.
And the power of regret and how looking backward moves us forward. Dan has written just an incredibly compelling and highly acclaimed book about research in psychology, neuroscience, economics, and biology that really challenges the widely held assumptions about emotions and behaviors about regret. So I'm not going to spend a lot of time. Dan, thank you so much. I know you've had an arduous journey to get to where you are. And thank you so much for taking the time. And we hope that by bringing this conversation together in our year-long dive into social determinants of health, and we're so grateful that you're going to be providing everyone a book. We're thrilled, and taking time to talk with us and answer questions and talk about the book specifically. Welcome.
Thank you, Holly. And just let me know in the chat if you guys have problems hearing me. As you can tell, I'm at the airport, so you're going to see people in the background eating and walking and running and arguing with each other. So get ready for that. So, I'm glad to be with you. So I just want to tell you some of the big ideas of, one of the big ideas, two of the big ideas of this book. But I'm really interested in talking a little bit more about your concerns and how to connect it to your good work. So if you think about, what people believe, there are various different ways to express how deeply we believe something. So in politics, we can put a sign in our yard. That's happening in Washington, D.C. right now. We have a primary coming up in a couple of months. You can put a bumper sticker. You can put a bumper sticker on your car. You can wear a button. So look at this. Like, here's somebody with a tattoo. All right. So a tattoo is a pretty serious commitment to a belief, right? And so here's a woman who I met. She's in Massachusetts. She has a tattoo that says in French, "Non, je ne regrette rien." No, I regret nothing. So there's this belief system out there that we should not have regrets. That regret is bad for us. That it weakens us. That it brings us down, and that courageous living is saying that you have no regrets, never looking backward, always looking forward. This is a widely held belief, and it's nonsense. That's the main point that I want to convey to you. It is unscientific, and it is a unhealthy blueprint for living. And I say that now, when you make a claim like that, it's very important for people to understand, for generous people like you to be skeptical as well, and say, how do you know, Dan? How do you know that? Well, I'll tell you, I'm going to show you the three ways that I know. Number one, is that there's 50 years of research, as Holly was mentioning, in neuroscience, in social psychology, in developmental psychology, in economics as well, showing how regret actually works. I did my own piece of very large survey research, the largest public opinion poll ever conducted on American attitudes on regret. And I also collected regrets from a lot of people all over the world. So what I'm going to tell you is that we know two core things. I'm not going to torture you with a lot of the science because there's one aspect of this that I really want to dive into. There are two things that we know about regret, and let me tell you the first one. Number one, regret makes us human. Everybody has regrets. Please, if you remember nothing else, remember this. Everybody has regrets. Everybody has regrets. Truly, we have 50 years of evidence saying that the only people who don't have regrets are 5-year-olds because their brains haven't developed the dexterity to process regret, people with certain kinds of brain lesions and neurodegenerative disorders, and sociopaths. The rest of us have regret. It is one of the most common emotions that human beings experience. It is arguably the most common negative emotion that human beings experience. And so we have 30, 40, 50 years of evidence showing this. Now, I wanted to test this proposition myself in this very large public opinion poll that I did. Working with a data analytics company called Qualtrics, we put together a sample of 4,489 Americans, representing a large sample so that we could weight it to reflect the incredible demography of the United States. And we asked people this question right here. How often do you look back on your life and wish you had done things differently? How often do you look back on your life and you wish you'd done things differently? Now, I phrased this question in a particular way because I wanted to get past this no regrets fog machine. So I'm describing regret, but I'm not using the R word. So when you ask the question this way, let's take a look at what people say. 1% say never. 1%. They never have any regrets. These are probably the 5-year-olds and the sociopaths. 16% say rarely. Meanwhile, you have 83% of Americans say this is something they do at least occasionally. Once again, confirming that this is a ubiquitous emotion that people have. Now that raises an interesting puzzle, I think. You have this emotion that is pervasive, but it's also aversive. It is ubiquitous, but it's unpleasant, all right? I don't like regret. So why is something so unpleasant, so pervasive? And the answer is, because it's useful if we treat it right, because it helps us if we treat it right. Here are some Dutch scholars who have a nice way of putting it. People's cognitive machinery is pre-programmed for regret. Regret is part of our brains. It helps us if we treat it right. And I want to keep coming back to that phrase, if we treat it right. And there's a pile of evidence showing that not only does regret make us human, but it can make us better. And this is the hidden facet of this research that I think is so remarkable, that if we treat our regrets properly, don't ignore them, don't wallow in them, but confront them, think about them, acknowledge them, learn from them. They are powerful engines for improvement and meaning. There is again, we can talk more about this in Q&A. Regret can help us make better decisions. It can help boost our performance on an array of tasks. It can deepen our sense of meaning. At a more granular level, regret can make us better negotiators. It can make us better strategists. It can make us better problem solvers. It can make us better parents if we treat it right. And so, this philosophy of no regrets goes against the science and is not an effective blueprint for living. And so, one of my missions in this work is to try to, I can't scrub away these tattoos, but scrub away this ridiculous idea that we should never have regrets and that regret is an inherently bad thing. Now, let me move to another aspect of this that is, I think, pretty interesting and maybe informative for your work. I was also curious about what people regret. So in my quantitative survey, what I call the American Regret Project, which was this giant public opinion poll that I just cited, I asked people to put their regrets in categories: career regret, health regret, romance regret, finance regret, education regret, whatever. And I found that people's regrets were all over the place. They were all scattered across many, many categories. There was no pattern to it at all. Other researchers had found out the same thing, that people's regrets run the gamut of the domains of life. And so I found that a little unsatisfying. But what I also did for an entirely different purpose was I established this thing called the World Regret Survey. It's still up there right now, where we just asked people around the world to share one of their big regrets. And to my amazement, we now have over 19,000 regrets from people in 109 countries. It's extraordinary. It's an extraordinary compilation of human aspiration and longing and emotion. And what I found there is that when you go beneath the domains of people's lives and actually read the language and excavate the language and analyze the language and go deeper into what they actually mean, something remarkable emerges. I read through the first 15,000 of these regrets, and what I found is that around the world, people have the same 4 core regrets. The same 4 regrets keep coming up over and over. Let me tell you what those are, then I'll tell you the implications of those, and then we'll open it up for some questions. The first are what I call foundation regrets. Foundation regrets. Now, this is a tricky one, especially for what you guys are talking about, and we'll come back to that in a moment. Foundation regrets, here's an example of it. This guy says, I regret not saving money diligently ever since I started working. It's nearly crushing every day to think about how hard I've worked for the last 25 years or so, but financially, I have nothing to show for it. Foundation regrets are small decisions early that accumulate to bad consequences later. We have a lot about saving and spending. We have some about health, which is related to, we'll come back to that in a moment. We have a lot about not working hard enough in school, et cetera, et cetera. So foundation regrets are this: if only I'd done the work. Next category, I can tell you this story about this, I think pretty interesting story. There was this, one of the people who filled out the survey was a guy named Bruce. Bruce, he didn't want me to use his last name. Bruce is 62 years old. He lives in Spokane, Washington. And when he graduated from college in the early 1980s, he went and spent a year working on a farm in Sweden. And on his last week there, he decided to take a train around Europe to explore. And on one of those days, he's traveling on a train in France. And a woman gets on and sits next to him in the empty seat. That obviously doesn't know her. They start talking a little bit. It turns out that she's from Belgium. She's working as an au pair in France. And they start talking, and they start laughing, and they start playing word games. This is the early 1980s, on paper. They start leaning into each other. They start holding hands. And Bruce is like, this is like something out of a movie. This is incredible what's happening here. It's like, I can't believe that I have this instant kind of affinity and attraction and this bond with this woman who I've just met. It's like something, fantastical. So the train goes along, and it finally gets to Belgium, and she says, this is my stop, I have to get off. And Bruce says, I'll go with you. And she says, no, my father would kill me. And then Bruce doesn't know what to do. Remember, this is pre-internet, there's no Wi-Fi on this train, there are no mobile phones or anything like that. Bruce doesn't know what to do. He scribbles his mother's mailing address on a piece of paper, hands it to her. They kiss, she exits. 40 years later, 40 years later, this is what Bruce said in the World Regret Survey. I never saw her again, and I always wished I'd stepped off the train. Now, this is what it's called a boldness regret. There are lots of these, ladies and gentlemen. There are lots of these. You're at a juncture in your life. You can play it safe or you can take the chance. People, not all the time, but more of the time than I expect, regret not taking the chance. They regret not taking a sensible risk. Here's some other examples of it. This 35-year-old woman from California says, I wish I'd taken more career risks. I played it too safe. Here's a 53-year-old man from the UK. I haven't been bold enough in my work. I focused on not failing rather than succeeding. We'll come back to this in a moment. There are lessons for organizations in these regrets, believe me. This 59-year-old woman from Texas says she regrets not speaking up when I had something important to say and I was the only Hispanic woman on the executive team of a private company. I wish I had used my platform to jump into the conversations in the C-suite more often in an intelligent manner. I had done my homework. I could have positively contributed. Boldness regrets, if only I'd taken the chance. Moral regrets, good one, small category, but really interesting. Here's a guy, 37-year-old man from Canada, says, I regret bullying a few different kids when I was growing up. When I think back on it, I cringe and can't help but wish for a chance to go back and change it. You're at a juncture. You can do the right thing, you can do the wrong thing. Most of us, when we do the wrong thing, we feel bad about it, we regret it. So lots of stuff here about bullying, marital infidelity, other kinds of moral breaches. Moral regrets are, if only I'd done the right thing. Final category, connection regrets. Here's an example from a 47-year-old woman in California. She says, I deeply regret not reaching out to a childhood friend while she was fighting cancer. When I finally called her home, I learned she had passed away earlier that morning. Connection regrets are about relationships, the full gamut of relationships that we have. Not only romantic relationships, in fact, mostly not romantic relationships. Relationships were intact, or they should have been intact, and they come apart. And they usually come apart in profoundly undramatic ways. They drift. One person wants to reach out, they say it's going to be awkward if I reach out, and the other side's not going to care, so the drift continues. Connection regrets sound like this: if only I'd reached out. Now, let's go. I think that these 4 regrets are powerful in and of themselves. I think they're fascinating in and of themselves, but I also think they tell us something. They tell us something really important. These 4 regrets, to my mind, are a photographic negative, a reverse image of the good life. When people tell you what they regret the most, they're telling you what they value the most. I want to say that again because I think it's important. When people tell you what they regret the most, they also are telling you what they value the most. What they value the most. And so these regrets give us a sense of what people ultimately want out of their lives. And I think it all, and so we can look at this and say, foundation regrets, if only I'd done the work. They're about stability. A good life is stable. A good life does not have a wobbly platform. Now, I want to make a point here about these foundation regrets, is that they're tricky, because regret requires agency. Regret is your fault. And so at times there are people who are saying they have foundation regrets, but they're not really their fault. And this is a very, very important point. So if I hear somebody, I interviewed the guy who had all this debt and never saved any money, and he was totally his fault. But if you tell me that, if I hear from a 38-year-old person who says, I haven't been able to save any money, and I'm 38 years old, and I find out that that person was the first person in her family to go to college, that she accumulated $200,000 of student debt, that she's taking care of family members, that's not on her. And so with foundation, one of the things that regret forces us to do is determine where we have agency, where people have agency and where they don't. And what's more, it also gives us clues about the conditions in society we want. We want to establish conditions where people have stability. That is, if the point of public policy and nonprofits like yours are to establish a good life, then an aspect of that is making sure there is some stability in people's lives. A good life is not precarious, and the foundation regrets teach us that. Boldness regrets, if only I'd taken the chance. That's all ultimately about growth. What do people want out of life? They want to learn, they want to grow, they want to do something. We recognize we're mortal, and we don't want to throw away our shot. We don't want to squander our limited time here. We want to learn, we want to grow, we want to lead a psychologically rich life. Moral regrets, I'm convinced that most people want to do the right thing. Overwhelming numbers of people, that's not even close. And a good life is a life that is good, a life that is moral. And that gives us clues about how to fashion both our own lives, the lives of the people we care about, and the organizations in which we operate, and the public policies we put in place. Then connection regrets, if only I'd reached out. That's ultimately about love. And that's what people want. And it's not only romantic love. We've sort of over-indexed on romantic love. I'm all for romantic love, but we have to have a wider notion of love, the love we have for our other members of our family, and the love we have for our friends, and the love we have for our colleagues, the love we have for our neighbors. And so these 4 core regrets give us some clues about how to build a good life and how to build a good organization. So let me stop there. There's so much other cool stuff to talk about, but let me...
Well, thank you so much. That was a super insightful presentation. I can kick it off with the first question. I'm curious how you suggest avoiding ruminating on regret and moving forwards from that regret to make meaningful change.
Yeah, that's a great point. So when I think the bigger point, April, is that no one ever teaches us how to do that. No one ever. I think we have a big problem in this, especially in this country, with negative emotions. We're over-indexed on positivity. We think we're supposed to be positive all the time, and we think that when we're not positive, there's something wrong with us, and that is foolish, and it's unscientific, because we have negative emotions for a reason. We should have more positive emotions than negative emotions, but negative emotions exist for a reason, and we have to do a better job of learning how to contend with them. So to your point, I think that there are, in dealing with retrospective regrets, there are 3 the most important step in stopping that march to rumination is how we frame the regret in ourselves. When we make mistakes, when we screw up, the way we talk to ourselves is brutal. It's vicious. We talk to ourselves in ways that we would never talk to another human being. If you were to broadcast my self-talk like into this airport here, people would think I was a lunatic. If I were to use my self-talk in a workplace, I would be fired. All right? And so don't do that. Instead, there's a whole body of work in what's called self-compassion, started by Kristen Neff about 20 years ago at the University of Texas. And self-compassion is very simple and very straightforward. And what it says is this: in the face of your missteps, treat yourself with kindness rather than contempt. That's the most important thing. Treat yourself with kindness rather than contempt. Recognize that your mistakes are part of the human condition. A lot of times we think we're more special than we really are. We think that we made a mistake, and our mistake and our screw up is singular. No one has ever done it before. We're completely unique, and we're not. I mean, I got 19,000 examples of that. And then also recognize the temporal aspect of it, which is that your mistake is a moment in your life, not the full definition of your life. And so that April can arrest the march toward rumination. Now, that's necessary in processing regret. I don't think it's sufficient, but it's a very important step. And your question is very well taken, because what happens too often is that we're taught to ignore regrets. And that can work for a little bit, just like I can block out the noise by going blah, 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 you know. But that's not a long-term strategy. And so what happens is when we are no longer able to ignore regrets, they overwhelm us, they debilitate us, and we end up wallowing in them. And that's bad. That is bad. What we have to do is we have to systematically deal with these regrets. We have to have a process, a habit, a method to deal with that. And when we do that, there is so much evidence that we emerge on the other side better.
Hi, Dan. I want to ask a question if I can. So I'm pretty convinced I've got regrets across your 4 domains, and repeated. And
congratulations.
And so is a usual individual got regrets confined mainly to one domain, or they're just across everything and repeated? Is there a frequency for regrets?
That's a really good question, and I actually don't know, because in the qualitative survey, the World Regret Survey, I asked people only for one, and so I don't know. My guess, and Francine, it's only a guess, is that they're reasonably widely distributed across people's regrets are reasonably widely distributed across domains. But what I do see in the total population, not necessarily for an individual, is that the 2 biggest categories are connection regrets, number 1, and boldness regrets, number 2. So I'm not sure that I think that people are less likely, I mean, I just know statistically from the 19,000 regrets that we have far fewer numbers of moral regrets and fewer numbers of foundation regrets. But huge numbers of connection and huge numbers of boldness.
Hi, Dan. I actually have a question from Elena in the audience, and
okay.
She was wondering, how do you start this process of learning from your regrets? Which is also a question that I had when I was reading the book, which is like, where do I start?
Great question. So what I would do is pick one regret. Pick one regret and work through this process. Now, the first part of the process is inward. So you reframe how you look at yourself and the regret, and that's self-compassion. Okay? As I said to April, that's necessary but not sufficient. The next step is actually important, and there's a very strong argument to make for disclosure. Now, it makes some of us uneasy sometimes. But what you see is that disclosure is a form of unburdening. Disclosure is also, and this is important for leaders, disclosure is also can help build affinity. We think erroneously that when we disclose our mistakes, our vulnerabilities, people will think less of us. There's 30 years of behavioral science saying that in general, not in all cases, but in general, people think more of us when we do that. And so disclosure is an unburdening, and it's a way to build affinity. The other thing that disclosure does, even if you're skittish about disclosing it widely to the world, is that emotions by their nature are blobby and abstract. That's what makes positive emotions feel so good, right? It's hard to describe something like joy. We know what it is, we like the feeling, but it's hard to articulate what it is about. And so negative emotions are also blobby and abstract, and that's bad. But when we write about them, talk about them, we convert them into language, which is more concrete and less fearsome. So that's the outward. And then the final thing is that you gotta go to this next step. You gotta draw a lesson from it. You gotta draw a lesson from it. You gotta say explicitly, this is what I learned and this is what I'm going to do. And we can talk more about ways to do that.
Thanks so much, Dan. A great discussion. I'm just wondering how you can support somebody who has been paralyzed in their life by perhaps a decision that was made, or they've got regret about a decision that was made by somebody else. Say they didn't win a job or a role, or they didn't make the ultimate sporting team for them. Do you have any guidance to support somebody? I couldn't work out where it fitted in the regrets.
Yeah. So interesting one, because that is sort of on the border between regret and disappointment. And those are two different emotions. Disappointment is external circumstances entirely, whereas regret is your fault. And so a great example of that is from Janet Landman at University of Michigan, who says, she tells a story of a 6-year-old girl who loses a tooth, and she puts that at night before she goes to sleep, she puts a tooth under her pillow, and when she wakes up in the next morning, the tooth is still there. So she's disappointed, but the parents regret not replacing the tooth with $1. All right, so there's agency involved there. So for the kind of things you're talking about, it's sort of on the murky border a bit. I would try to. I would do a couple of things there. Number one, I would go for self-compassion. I think self-compassion is one of the most versatile combination of versatile and unused tools that we have in our toolkit. It's really powerful, and I encourage you, to look at the book and even at the footnotes in the chapter on self-compassion. There is so much research on this. It is powerful. The other thing is that you can also do what's known as a downward counterfactual. A downward counterfactual, which what I like to call an at least. And regret is an upward counterfactual. You say, if only things had gotten, you imagine how things could have been better. There's also, you can do a downward counterfactual and imagine how things could have been worse. So you could say, I didn't get that job, but at least I didn't have to move to St. Louis. I didn't get selected for my 7th grade basketball team, but at least I used that time to work on the school newspaper. And so these downward counterfactuals and at least can take some of the sting out of that regret. And it sounds like in the situations you're talking about, that taking that sting out is actually fundamentally important.
So my question was, so you've laid out an incredibly helpful process that encourages us to look back in order to move forward. So what advice do you have for us as we engage in this process when we're thinking about systemic issues like the social determinants of health?
It's a really important question, and I think that I don't want to suggest that I have any expertise on that particular domain, on the social determinants of health at all. But I think, though, that we can take this issue more broadly, and I think it's something this country is reckoning with right now. Maybe not in part on social, not directly on social determinants of health, but it's basically about what are the virtues of looking backward. And we're having this fight right now in our schools, and big time. And we're not approaching it right, because there's one view that is like, we ignore that. We completely ignore that. We don't talk about that. What are you talking about? Okay, that is delusional. That is not healthy. There is, I think it's less prominent, but there's another side, or at least the fear of the other side of wallowing in it, of saying, oh my God, we are scarred forever. We are fundamentally flawed. We are a completely broken society. We are helpless in doing anything. That's a kind of form of collective wallowing. I think that's dangerous too. I think what we want to do is we want to confront these things. We want to think about them. We want to think about them, and we want to actually work through a process. And this is something I've discovered, I think, after the book is out more robustly, is that we don't have, we do better as human beings and as organizations when we have systematic ways to deal with complicated, difficult things, right? When we have a process we can go to. So if you look at so this is one reason why I think faith traditions do a better job of dealing with negative emotions in secular society. I mean, every faith tradition has a way of dealing with grief. But faith traditions some faith traditions have a way of dealing with regret. Catholicism has confession and repentance. Judaism has a day set aside in the calendar for atonement. Even something that's quasi-religious, like AA, or Alcoholics Anonymous, has a process. And so I think what we want to do is do this process and say, let's take it at a national level. We look back and say, man, this country did some bad things. Like, there's some fucked up things that in our past, and you can say, and what you have to say is like, okay, well, like every human civilization has things like that. All right, so we don't have to have contempt for ourselves. We should actually treat our nation with some degree of kindness. So that's the first step. The second thing is, let's talk about it. Let's air it out. Let's not conceal it. Let's have that disclosure. Let's make sense of it by shining light on it and by talking about it and writing about it. And then the third step is, let's find a lesson. Let's find a lesson from it. Let's get it. The third step in all of this is you have to extract a lesson from it and say, this is what we learned and this is what we're going to do about it. And I think that can work at a national level. Now, with regard to social determinants of health, there's no question. Come on. I mean, you guys already know this. If you are a person of color in this country, you have worse health outcomes, period. Do you think that's not a genetic? That's not a genetic force. That is a social force, and we have to confront that. And so I think the more we get into the habit of not ignoring and not wallowing, but confronting and in giving people the scaffolding to do that in a systematic way, where we look inward and treat ourselves with kindness rather than contempt, we express outward and disclose and make sense of it, and we extract a lesson from it. You can't have those first two. You have to extract a lesson from it.
Dan, thank you so much for that. And just to follow on from that comment, I don't think America's alone in all the things that you're talking about, with racism here in Australia. It's not dissimilar. So please don't, feel you're alone in that one. You've actually probably answered a bit of my question, but about 12 months ago, I was making a large career decision, and I spoke to my dad, and he was, my idol. He told me all these regrets that he'd had during his work life, and it really has changed our relationship and our dialogue. And I guess my question is, why don't we share our regrets with others? Are we, why?
Such a good question. Such a good question. And I'm glad that the representative of a formal island penal colony says the United States isn't all bad. So thank you for that on behalf of my fellow citizens. So it's a great question. I think it has to do with feelings of embarrassment and shame and a sense of, as I was saying before, a sense of singularity. That is, here's the thing. It's like you never want to tell Americans that they're not special, okay? But we're not special. That is, I can take any regret from anybody. We could list all of our everybody on this place and this call could list, we have 45 participants here, so everybody can list four regrets. All right, so that's 180 regrets. All right, I can guarantee that for all those 180 regrets, I can go into my database and within minutes find another regret like that. I mean, because it's a belief that we're more singular than we really are. That's one thing. The second thing is that we've been sold a bill of goods about positivity, so we think we need to be positive all the time, and we don't have any experience doing it, and so I think those three things together make it difficult. What I have found, and Louise, the whole reason I got into this topic was because I started talking about my own regrets. Truly, this is, if I give you guys one piece of advice, it's this. It's like this week, have a conversation with someone in your team, someone in your family, your neighbor, and tell them one of your regrets. Tell them what you learned from it, and tell them what you're going to do about it. It is a transformative conversation, and it has a cascading effect in giving people ways to deal with this. I don't want to go into the whole long story here, but I had this moment when my elder daughter graduated from college, and it was like sort of a marker in my life, and I started thinking about my own regrets, because it's just sort of that marker in time. And when I came back from this graduation and just started very sheepishly telling people about that, I found that they leaned in. And I don't mean lean in metaphorically. I mean lean in literally. I mean saying, "Oh my God, Dan, I have that regret too." And that kind of reaction was so powerful and so palpable that I actually put aside an entirely different book that I was writing and started doing research on regret, and actually got out of my initial contract because I so badly wanted to write about this topic. Because I find that when we talk about it, it's transformative. It's transformative for the individual who talks about it. It's transformative to the person who hears it, because they realize that they have those kinds of regrets too. And it's transformative for the society, because we start having honest conversations rather than the bullshit of no regret or the despair of wallowing in the regrets.
I agree, Louise. That was such a good question, and a good question for us to end on. Such an incredibly big thank you, Dan. I've been able.
Yeah, I'm sorry I was so late. I'm glad we were able to answer all these questions. I'm going to put my here we go. Kelly has this, but if you guys have more questions that you think of while you're reading the book, just here's my email address. Just send me an email, and I'll try to answer it. I'll do my best to answer it directly.
Yeah,
but
it's incredible, you guys. I mean, what Dan does in his research and writing and making us smart, it's also up to us to make sure to support the writers of our time, and we're helping you do that, because
I appreciate
Dan's
that.
work is so valuable. And Dan, no one, it is just so not for the faint of heart what the work is that you do every day in terms of the predictability and just all of that. And this has got so many intersections, you can see with this work that we're embarking on for the year. So, phenomenal speakers. I know, Dan, that you were really excited to come with us from the beginning today to see Felicia and Fran talk. And so we'll make sure that you do that. They wanted to ask you about your biggest regret, and we will connect some of the other questions to you. But, we just say thank you so much to Abbott Diabetes Care, to Insulet, for Novo Nordisk. You guys are the ones who are making this possible. And, thank you to our community for sharing, asking questions, helping create the Wild community. I'm just so moved when I look at all the names and faces that have been in and around the screens today. So, big time to Abbott, Insulet, and Novo Nordisk as leaders for providing us the opportunity as emerging leaders to learn, connect, and take action on many issues, but particularly on helping us do the initial learning and unlearning on social determinants of health. You heard Dan bring up, just a piece of this, and Dan, we want to bring you more into these conversations. Despite the advances that we see, we heard from Felicia at the top of the hour, 25% of African Americans, 25% live below the poverty line, right? We put so many connections together when we're learning some of this. So this was just a starting point in the conversation on social determinants of health for the Wild community. And now that we have an amazing crucial foundation from Dr. Hill-Briggs on knowledge, we invite everybody to our quarterly sessions where we're going to take deeper dives into what we can learn from the challenges and really get into the root cause, right? We're also piloting an in-person Wild event at the ADA in June to go to the Whitney Plantation together or separately, whatever works for you. But look out for information on this. And we really want to provide some opportunities for the community to connect over their learning. And this one will even be with refreshments. So thank you all for taking such an important step in your leadership and in joining the conversation today. Please ask your colleagues to look out for our video that will be coming out very shortly with today's talks. And, I'm always looking forward to seeing you throughout the year. Dan, for you to just land and to stay on a little longer with us was absolutely incredible. Again, everyone, if you don't have the book yet, we've sent some of them out, but if you haven't got it yet, you'll be getting it. Again, The Power of Regret. And after this, we'll say that we are going to be immersed in the learning. Dan, if there's any one last thing, like how can we help you in your journey with this book? You're looking at such an incredible.
Kelly, just do. I mean, seriously, like the best thing is this week to tell somebody about one of your regrets. Tell them what you learned about it, and tell them what you're going to do about it. What you learned from it and what you're going to do about it. I'm telling you, it's a catalytic conversation. It's a catalytic conversation. There's not been a single instance where that conversation hasn't had at least some meaning and affinity building, and I think that's the key. I think that everything, it's like what you guys are doing. It's like I've said this before many times. It's like everything good in life begins with a conversation. So have a conversation.